anterior because I see the orifice of the vein. Exactly right there. I just brought the ablation catheter to the inferior part of the right inferior pulmonary vein, release the curve, going to the superior part of the right inferior pulmonary vein. Superior part, inferior part. Now, let's look at it. We put the mapping catheter inside the right inferior pulmonary vein. Remember sitting on the mitral valve? When I'm looking at the right inferior pulmonary vein, if I counterclock, I'm going to see a wall. That wall is the posterior part of the right inferior pulmonary vein. I just burn it. I don't see the vein. I have already done the superior part of it, inferior part of it. Now I counterclock my eyes. I'm doing the posterior part of the vein. Right there. And of course, again, you see it on your mapping system as well, that you are in the posterior part of that very right inferior pulmonary vein. So if I'm looking at the right inferior pulmonary vein, this time I go and clock it. Remember, you're sitting on the mitral valve, you clock it more, you see the septal part of that right inferior pulmonary vein, which is right here. You don't see the vein anymore. You did the superior, inferior part of it, you did the posterior part of it. Now you are doing the anterior part of it. And sometimes you can see your lesion, actually, the lesion formation, which is mainly because of the edema formation and stuff. So you see it, and of course, the moment you see that is happening, this right there, you want to move on and go to it because you don't want to cause any stim pop or so. So it makes it very safe to be able to see all this lesion formation many times during the catheter ablation. So here is the lesion formation, you just see it there. This was the right, anterior part of the right inferior pulmonary vein. And here, we are in the right inferior pulmonary vein, anterior part of it. And you can appreciate it here. Really, sometimes I tell my techs, why did you stop burning? They say, oh, we didn't. It timed out. You can see that sometimes you can do all the veins with single burn from the beginning to the end. This is, sometimes it really stops. And we have done perhaps all 4 veins with 1 burn. Here, let's look at the roofline. My eyes, again, is inside the left atrium. I have the right superior pulmonary vein. I have the left superior pulmonary vein. What is the area in between? It's going to be the roofline, correct? So if I ablate from here to here, I can do a continuous movement of my ablation catheter, and you can see lesion formation here. I just need to burn from here to here. So I see that how continuous my lesion would be. I see that if I'm missing, I'm going to be able to come back to that area and ultimately make sure that I get clearly. You can appreciate here, this is another patient. Patient is already in AFib. You can see right superior pulmonary vein, left superior pulmonary vein, and this is the descending aorta. And you can appreciate that this is the roof between the left superior and the right superior pulmonary vein. So you can make a roof line just by looking at your intracardiac echo and burn from here to here and finish that entire roof line. Remember, you do have your mapping system as well. So that would help you as well. So you know that you're really burning there if you, at the very beginning, if you have any doubt. How about the floor line? So if you would be able to look at your left inferior pulmonary vein and get you, to the right inferior pulmonary vein. Here we are getting, this was a case that we are doing the geometry right now, activation with the this grid catheter here. And you can see that my catheter is inside the left inferior pulmonary vein, right inferior pulmonary vein. So what is going to be in between? This is going to be the floor line, and this is the descending aorta. So I just need to, you can see here, it goes from left inferior pulmonary vein, as I showed you on the mapping, just went to the right inferior pulmonary vein. And the area in between is going to be, of course, the floor line. And you can see the descending aorta here as well. And here you can see on the mapping system that you perform a floor line from the, so here, this is during the case, interestingly, this was in a fib, as we are trying to perform, we were trying to start a pulmonary vein, a posterior wall, we were just getting a little bit, more organized rhythm. And as we are trying to finish the, posterior wall, you can appreciate that it went to a slow ATAC and some extra beats and terminated, the tachycardia terminated here. But when you look at that, when you look at this, interestingly, you can see that the posterior wall is dissociated here, but there is still posterior wall there. Many times it is epicardia. You got to go and find that area and then make sure that, find the earliest spots, get rid of it, and make sure that your posterior wall, of course, is completely without any voltage. Some cases you may need to do ablation of the coronary sinus. Here, I usually don't go above 35 or 40 inside the coronary sinus. This is for persistent, of course. And here you can appreciate that the catheter is coming from the distal part of the coronary sinus. But with the ice, you can also look at it. This is the ablation catheter inside the coronary sinus, and this is my decopolar inside the coronary sinus. So I would be able to see that I'm really touching the wall. I know that bubble formation. And remember, mapping system may have a more delay than the ice. So you can, even if it comes out of the CS, you can see it immediately. And here, I'm doing the endocardial aspect of the very coronary sinus that I was burning. So I'm doing the LA part of that. I was doing the epicardial, now I'm doing the endocardial. Because of the shortage of time, I didn't put the LA appendage, but I'm gonna just put a SVC appendage here. So you can see this is the SVC. This is my circular catheter for mapping, right atrial appendage, which means this is anterior part of the SVC, ablation catheter here. So you know the septal area is going to be somewhere here. So we are doing the posterior wall of the SVC here, ablating it. If I advance it towards here, I'm going to be ablating the anterior part of this very SVC, like by the right atrial appendage. And if I go into the SVC, and usually you have to use the F curve, and you can do, again, a candy cane here, and just make it, and then when you have this candy cane, you can just go down, rotate it 360 degree, and perform this entire, SVC with one circle of 360 degrees. We are going to now completely switch the gears. We are going to go to the VTEC ablation. I'm going to show you a few things of RVOT and RV-PVC ablation here. Let's again look at the structure seen in the home view. You can see the CTI. You can see the region of the His. You can see the right ventricle and RVOT. So in order for us to go, of course, we are going to go place the ice inside the RV. Sometimes it really results better visualization, especially for the RVOT. You can see the RVOT from here, but if I place the ice inside the RV, here we went to the RV, you see that those two dots are in the RV. I just go and clock it. I'm inside the RV with the ice. I can see the LV. If I continue clocking more, I'm going to be able to see the right ventricular outflow tract. And here you can appreciate the RVOT here. So you can see here that this is the RVOT and this is PA. So this is a kind of upside down view, like patient legs are here, feet are here, and patient head is this way. So this is upside down view, and you can see the RVOT, you can see the pulmonary artery, right coronary cusp and left coronary cusp. So you can appreciate the proximity of them to each other. Here you can see that the ablation catheter here, the PVC was coming a little bit inside the pulmonary artery, but the problem was that, if I put the ablation catheter, this valve is not going to let me touch this tissue very well. So it would prevent from a good contact. So what you can do when you see that that area is above the valve, again, you can go in a little bit here like that, and you can perform the candy cane maneuver. Here you can pull it down, curve it, and right now I just went right on top of the valve. As opposed to coming this way, I came here, and you remember this is an upside down view. This is a pulmonary valve, RVOT, pulmonary artery, and this is the ablation catheter. You may do, you know, when you do this candy cane maneuver and U-curve, it gives you a better contact. And you can also do the upside down, and now you can see a real view that head is this way. It is like a pediatric kind of echo, and the feet is this way, and you can see that RVOT, and this is a pulmonic valve, and this is my ablation catheter, a candy cane coming right above the pulmonary valve. Have a very good contact. Again, you can go back and forth, and you can see it here that I went back up, and you can see this kind of reverse view. You can go down, remove your U-curve, pull it back slowly, and here you can see that again, if you are in this area, let's look what is adjacent to it. So if you cannot get it from here, of course, you can see the right coronary cusp right there. That's why we say that, you know, you have to check both many times. And look at that. You can see now my catheter is in the right coronary cusp. So this is RVOT and PA. The ablation catheter is in the right coronary cusp. And you can see the same patient, RVOT, PA, right coronary cusp, but this time ablation catheter is right on the other side of it, right here on this side. And if you, of course, go a little bit further, you see the left coronary cusp is there. So here you can see the longitudinal view of it. You can see my ablation catheter came to the right coronary cusp, as opposed to here, my ablation catheter going to the RVOT adjacent to the right coronary cusp. Here we have it here. Here we have the ablation catheter on the other side of it. And that is in the ablation catheter, right coronary cusp, and RVOT is on the other side. So it really helps you with the maneuvers. This is another case that, interestingly, you can see that sometimes how you see that Dr. Asivatam very elegantly has shown us this, that this, you know, the muscles go beyond the pulmonary valve, and you can clearly see it. This is an extension of RV muscle into the pulmonary artery, and I had to go above the pulmonary valve and go on the top of the muscle to be able to get rid of this PVC. This is an example of the PVC ablation, which is originating from the right ventricle. So if you notice here, this is a V1, so transition is very late. 2, 3, 2 was positive, you know, 3 and AVF, I believe, was a little bit still positive. But interestingly enough, you can see, let's look at this to see where this PVC was coming from. So this is my ICE catheter. You see the eustachian valve here. That was the CS. And my ICE catheter is in the right atrium. You can see my ablation catheter. I have made a U-curve, and I'm at the lateral view of the tricuspid valve. So this is a septum. This is a lateral. This is a tricuspid valve. This is a right atrium. This is a right ventricle. You can see the ablation is right under the valve, right there. And here you can see ablation actually came to the right atrium. You see? Then you say, oh, I just saw that atrial activity. Yes, because the ablation just came to the atrial side of it. I release the curve, go back, and go inside the right ventricle under the valve. So this is the right atrium. This is a valve, right ventricle, and I'm right under the valve. And this PVC was, interestingly, was coming from this very area, which was lateral part of the RV, right there. And of course, you have your mapping system, and you can create the geometry as well as the voltage mapping, which is very crucial. So here you can see the medial side is CS, RV, RA, and this is the lateral side. And again, you see the RA, and here you can see that that was the very early activation, which was right under that tricuspid valve. Again, this is the right atrium, this is the right ventricle, and that is the very area. And the medially, we were very late. So, and this is the CS, and this is the right atrium and right ventricle.